Hey everyone, and welcome. I am so thrilled you're joining me for this explainer. Today, we're going to completely demystify a biological reality that every single one of us knows intimately, but honestly, very few of us actually understand. We are talking about pain. By the time we wrap up today, we're going to fundamentally shift how you view your body's ability to detect danger, process injuries, and ultimately construct that sensation we call pain. It is a wildly complex, highly adaptable system. So let's jump right in. Picture this for a second. You accidentally touch a hot stove. It burns, you instantly yank your hand back, and it hurts like crazy. But I want you to think about a pretty profound question. Where does that pain actually happen? Well, your instinct is probably to say, in my hand, obviously. But as we're going to see, that's not exactly true. Your hand definitely detects the danger, but the pain itself, that is an entirely different story. All right, let's really dive into this because we need to draw a hard line between two very distinct things: nociception versus pain. Nociception is simply the neural process of detecting and transmitting potentially harmful signals. It's just a neural reflex. It happens entirely in the background of your nervous system and requires absolutely zero conscious awareness. On the flip side, we have pain. Pain is a conscious, sensory, and deeply emotional experience. And here is the absolute kicker. Pain occurs entirely inside the brain. Your body detects the danger, sure, but it's your brain that actively creates the pain. So how does that danger signal actually reach the brain? Let's trace the chronological journey of that stove burn. First, you get tissue damage. The intense heat literally ruptures cells in your skin. Second, those damaged cells burst wide open and release this massive chemical soup of inflammatory markers. We're talking potassium ions, bradykinin, and histamine. Third, that chemical cocktail activates specialized sensory nerves called nociceptors, essentially tripping the body's alarm system. And finally, step 4, that alarm signal is transmitted right up to the central nervous system. Now, let's zoom in on those nociceptors for a second. These sensory neurons are your body's ultimate first responders. And what's cool is they aren't activated by just a gentle breeze or a soft touch. They have a naturally high threshold, meaning they literally sit around waiting for intense, potentially damaging stress. To do this, they use very specific ion channels. You've got TRP channels that detect painful, scorching heat, piezo channels that physically stretch and pop open under severe mechanical pressure, and other channels specifically tuned to those chemical irritants we just talked about. And those first responders actually come in two main structural varieties: A delta fibers and C fibers. A delta fibers have a special coating called a myelin sheath. It acts exactly like insulation on a copper wire, allowing electrical signals to conduct incredibly fast. C fibers, on the other hand, are unmyelinated. Because they don't have that insulation, their signals travel much, much slower. This hardware difference actually explains a phenomenon we have all experienced. Think about stubbing your toe on the edge of a bed. Remember that immediate, lightning-fast, sharp shock of pain? That's your first pain, delivered hot and fresh by those fast, insulated A delta fibers. But then, you know what happens a second or two later, right? You get that creeping, deep, drawn-out, throbbing ache that makes you want to hop around the room. That is your second pain, arriving late to the party because it's slowly making its way up those uninsulated C fibers. Okay, so both of these signals are racing from your injured toe, up your leg, and into your spinal cord. But here's where the story gets super fascinating. Once the signal reaches the spinal cord, where does it actually go inside the brain? You'd probably guess it goes to one specific pain center, right? Well, actually, it splits into completely different geographic pathways. First up, the signal shoots up what we call the lateral pain pathway. This moves along the spinothalamic tract directly into your somatosensory cortex, which is the part of your brain that basically acts as a physical map of your body. This pathway is blazing fast, super precise, and highly localized. Its entire job is to answer two very practical questions. Where's the damage, and how intense is it? It's the pathway that lets you instantly pinpoint that the sharp pain is exactly on the upper left corner of your right pinky toe. But at the exact same time, that signal is also traveling up the medial pain pathway. Rather than mapping the physical location, this pathway dives deep into your limbic system and the anterior cingulate cortex. These are the emotional centers of your brain. This pathway is entirely focused on answering, how does it feel? It drives the distress, the intense suffering, that deeply rooted autonomic panic. It's what creates that miserable, all-consuming ache that commands your attention and absolutely forces you to rest. Now here is where things get truly mind-blowing. Up to this point, we've kind of talked about the brain as just a passive receiver, right? Just sitting up there waiting for signals from the body. But the reality is, the brain actually has a massive say in how much pain you feel. It essentially has a built-in volume control knob. This is managed by the descending modulatory pathway. Your brain can actually send signals back down into the spinal cord, specifically starting from an area called the periaqueductal gray. These downward pathways release incredibly powerful neurochemicals like serotonin, noradrenaline, and your body's own natural opioids, endorphins. And this is totally context dependent. In a moment of extreme survival stress, high adrenaline, or maybe a massive athletic competition, your brain can flood your spinal cord with these chemicals and actively block pain signals before they ever reach your consciousness. Everything we've covered so far highlights a really beautiful, highly functional, and protective mechanism. It literally keeps us alive and stops us from destroying our tissues. But, unfortunately, we have to ask the difficult question: what happens when this incredibly complex system breaks down? Let's shift gears from normal, protective pain to the often devastating reality of pathological pain syndromes. Just to set a solid baseline, let's quickly review nociceptive pain. This is the normal, functional pain we've been tracking all along. It's caused by actual physical tissue damage that correctly fires up those high-threshold nociceptors. And it basically comes in two flavors. You have somatic pain, which is that sharp, easy-to-locate pain from your skin, muscles, or joints, and then visceral pain, which is that deep, dull, vague ache coming from your internal organs. In both of these cases, the system is working exactly as intended.
But then we have neuropathic pain, and this is fundamentally different. This isn't your body's reaction to touching a hot stove or getting a paper cut. This is pain caused by a physical lesion, a disease, or trauma to the somatosensory nervous system itself. The nerves aren't just reporting damage from the outside world anymore. The nerves themselves are damaged and misfiring.
And the problem can originate even higher up the processing chain, which brings us to central pain. This is a specific type of neurogenic pain triggered by a primary lesion directly within the central nervous system. Think about a lesion in the spinal cord, the brainstem, or the thalamus. The actual hardware processing the signal is physically altered. Contrast that with functional pain, like what we see in conditions like fibromyalgia. In functional pain, there's no obvious physical lesion you can point to, but the central nervous system processes totally normal signals in completely abnormal, painful ways. When these nerve pathways are altered, your central nervous system can undergo a process called sensitization, which leads to a condition known as hyperalgesia. You can think of this as a hyperreactive, cranked-up state. Normal danger signals are suddenly amplified to a totally unbearable degree. It's basically like a car alarm that's become so ridiculously sensitive that a single leaf falling on the windshield sets the whole thing blaring. The entire system just overreacts. Even more tragic is a condition called allodynia. This is a devastating misfiring of the sensory pathways. With allodynia, painful levels of activity are triggered by completely normal, light touch receptors. Imagine a gentle breeze, the brushing of a bedsheet, or a soft touch from a friend, things that are objectively harmless. In allodynia, those exact same sensations are suddenly registered by the brain as excruciating pain. A huge reason these pathological states can take hold is a simple loss of inhibition. Remember earlier when we talked about how the brain can turn down the volume using those descending pathways? Well, if the inhibitory controls in your spinal cord, like GABA or your opioid receptors, stop doing their jobs properly, the gates are just left wide open. The pain signals flow upward completely unhindered, locking the body into a state of chronic pathological pain. So, a crucial takeaway here is that pain is a highly subjective construction of your brain, and it's absolutely not a one-to-one ratio with tissue damage. Take this astonishing true story from our source material. A man whose arm was completely severed in an industrial accident calmly fished out his own limb, got in his car, and drove 15 miles to the hospital, literally stopping at traffic lights and parking carefully. In that moment of extreme survival stress, his brain completely clamped down on the nociceptive signals. Massive tissue damage, yet highly suppressed pain perception. Incredible, right?
That story beautifully highlights the mind-boggling power of the brain. We see it in stress-induced analgesia, where trauma actively blocks pain. But we also see the exact reverse, anxiety-induced hyperalgesia. This is where fear, high anxiety, and poor coping expectations literally amplify the physical pain signal. By the way, this is exactly why treatments like antidepressants can actually help reduce physical pain. It's not just about improving mood. They can literally enhance those descending anti-nociceptive pathways that block pain signals right in the spinal cord.
Which brings us to the end of our explainer today and leaves us with a truly profound question to chew on.
Given everything we've uncovered, from the microscopic nociceptors and ion channels to the deep emotional pathways and the brain's incredible built-in volume control, are we ever simply passively feeling our injuries? Or is our brain, constantly crunching data on context, stress, and mood, actively deciding what actually deserves to hurt? Thank you so much for joining me to explore the amazing physiology of pain. I really hope this changes how you view your body's most complex warning system.